Welcome back to RadOnc Smart Review, Thoracic Edition.
Glad to be here.
So, imagine you are looking at your treatment planning screen. The dose, it perfectly covers a central lung tumor.
Right?
The color wash is totally tight. The margins are crisp. I mean, it looks like this flawless, highly conformal plan.
Like a textbook plan, yeah.
Exactly. But what the screen isn't telling you is that the software algorithm just warped a previous high-dose region by like 2 centimeters.
Which is terrifying.
Right. And delivering this quote-unquote perfect plan today is going to cause a fatal hemorrhage in the patient's proximal airway in exactly 3 weeks.
Yeah. And that is the terrifying reality of thoracic reirradiation.
It really is.
We're stepping into this area where our standard tools, our dose volume histograms, our fusion algorithms, all of our biological models, they can actively lie to us if we don't know exactly how to, interrogate them.
And I think that's why we have to fundamentally shift our mindset today.
Absolutely.
We are talking about thoracic reirradiation and cumulative dose. And the core philosophy that you have to adopt right from the start is this idea that thoracic reirradiation isn't simply a second course of radiation.
No, not at all.
It is an entirely new, incredibly high-stakes treatment decision, but it's being made in the long, dark, often poorly defined shadow of an old decision.
I love that phrasing, the shadow of an old decision, because that shadow is cast by 3 really distinct layers of clinical uncertainty.
Let's break this down.
Yeah, so first you have to figure out if another local treatment is actually going to, meaningfully alter the trajectory of the disease for the patient sitting right in front of you.
Right. Does it even make sense to do this?
Exactly. And second, you have to figure out what physical dose the normal tissues actually received during that first course.
Which is much harder than just looking at a piece of paper.
Oh, way harder.
Mm.
And then third, you have to determine how much additional injury those specific normal tissues can biologically tolerate today.
Because of those uncertainties, if you're sitting at your workstation right now or walking into a consult, you might be tempted to ask the most dangerous opening question possible, which is, what dose should I prescribe?
Yeah, we have to completely train ourselves out of that reflex.
Totally. The much safer, more rigorous opening is to ask, what is the true intent here? Can I reliably reconstruct the past? And which specific microscopic layer of tissue is the one that could turn my, beautiful plan into a catastrophic event?
And to really ground this entire discussion, we need a patient. We aren't going to just talk in the abstract today.
No, we're going to build this logic around an active case anchor.
Right. So let's set up the patient.
Okay, so you have a patient who was previously treated with definitive thoracic radiation for non-small cell lung cancer.
Okay.
Fast forward to a routine follow-up. Surveillance imaging shows a new abnormality within the previously treated chest.
And you do the right thing here. You don't just trust the scan, you get a biopsy.
We skip the tissue.
Right. And the biopsy confirms a recurrent non-small cell lung cancer right there in the old field.
So we restage them, and the PET scan shows absolutely no distant disease.
Good. Let's look at the anatomy and the patient's status.
Yeah, the recurrence lies centrally. It's sitting right near the proximal airway and the esophagus.
But clinically, the patient looks great. They're functionally independent.
Right. They aren't on oxygen. They are swallowing fine. They have no severe unresolved toxicity from that first course of radiation years ago.
And they are looking at you, sitting in the exam room, asking for another attempt at durable local control.
But here is the missing link. You look at your chart, and the outside treatment summary from their previous facility simply reads, definitive radiation completed.
Oh, I hate when that happens.
It's the worst. It doesn't include the original planning CT. You don't have the structure set, the 3D dose grid, the beam angles, or the delivery record.
Nothing.
The actual digital DICOM files just have not arrived yet.
So we have a central recurrence, a healthy patient, and missing digital records.
It's so incredibly tempting to look at that isolated central tumor and immediately start debating technique.
Like, should we do SBRT?
Yeah.
Stereotactic body radiation therapy is great for isolated spots.
Right. Or should we do conventional fractionation?
But that is the wrong question to start with.
Then what is the true consult question?
The true consult question is a second course of radiation clinically justified? And can we establish a reliable enough estimate of the cumulative biological risk to actually recommend it?
Right, before we even talk about dose.
Exactly. If you were pressed for the 60-second attending level summary of this exact setup, it needs to hit a very specific sequence of logic before a dose is ever even mentioned.
So let's hear that ideal 60-second summary for our patient.
You would state that this is a potentially high-risk thoracic reirradiation case, demanding specialized multidisciplinary review prior to any prescription selection.
Okay, setting the stage.
Yeah, then you confirm the pathologic recurrence and the localized extent of disease. You'd explicitly define the intended benefit in this case, durable local control, not just palliation.
Right.
You would formally review all non-radiation alternatives. And regarding the missing information, you would state that prescription selection is totally deferred until the complete prior digital radiation record is obtained and processed.
So no rushing into a dose.
Never. Once received, you'd review the native plans, register the datasets, meticulously inspect the anatomical alignment around each serial organ at risk, and model the cumulative dose while explicitly documenting the uncertainty of that registration.
Wow, okay. And what about the final recommendation?
The final recommendation would depend heavily on the cumulative risk to the airway, esophagus, spinal cord, and great vessels. You would absolutely not rely on a universal constraint table to just prove safety.
Because those tables don't tell the whole story.
Exactly. If a clinically meaningful plan remains feasible across all reasonable registration uncertainties, then you select the fractionation that best balances control with avoiding catastrophic serial organ injury.
And finally,
You would mandate peer review, physics QA, and a high-risk consent discussion detailing the potential for irreversible or fatal injury.
that opening completely sidelines the technology until the clinical foundation is actually built.
Yeah, that's the whole point.
So let's slow this down and walk through that initial decision matrix. We need to look at intent, localization, and alternatives.
Because before we look at a single-dose grid, we really have to look at the biology of the tumor and the realistic options.
Intent is the unavoidable first step, right?
Yeah, the intent of your treatment dictates your risk tolerance. Reirradiation is done for vastly different reasons.
Like in our case patient who has localized disease, great performance status, and a realistic chance of long-term survival, the intent is definitive, or at least curative-like.
But intent isn't always definitive. Sometimes you have a patient where the tumor is invading the airway, and if you don't do something, they will asphyxiate in a month.
That's terrifying. So your intent there is really just to prevent a foreseeable catastrophic local complication.
Right. Or you might have a patient with widespread metastatic progression, and you just need to palliate a bleeding vessel.
And the level of cumulative toxicity you are willing to accept changes wildly between those scenarios.
Oh, completely. A patient pursuing durable local control might accept, say, a 5% risk of a late esophageal stricture if it means a real chance at a cure.
Yeah, but a palliative patient with 3 months to live.
They should absolutely not be subjected to a grueling 5-week course of radiation that carries a high risk of acute esophagitis and just destroys their remaining quality of life.
But here's the trap, right? You can't just slap the word definitive on a plan to justify it and then quietly carve out all the dose around the tumor just to make your normal tissue spreadsheet pass.
Yes, that happens so often. If you underdose the tumor to save the esophagus, you no longer have a definitive plan.
What do you have?
You have a palliative plan with definitive level side effects.
Wow, that is a great way to put it. Let's formalize this a bit. There is a 5-step logic for clinical justification that we need to walk through for every single reirradiation consult.
Step 1.
Step 1, is the target real? We see a mass on the scan. Why isn't that enough?
Because post-treatment thoracic imaging is just notoriously deceptive.
How so?
Well, radiation fibrosis, evolving pneumonitis, organizing pneumonia, they can all completely mimic a solid mass. The tissue has already been traumatized.
So a PET scan can light up just from inflammation.
Exactly. That's why we say tissue is the issue. A biopsy is strongly preferred whenever feasible, especially because confirming the exact histology might open up targeted systemic therapies instead.
Okay, and in our case, Anchor, we actually have pathologic proof.
We do. So that moves us to step 2. Is the disease localized?
We did the PT scan. We ruled out distant disease. That makes local treatment worth evaluating.
Right. And step 3. Is radiation the best local modality?
And I have to pause you here. I struggle with this one a lot.
A lot of people do.
Because if our patient goes to the thoracic surgeon and the surgeon looks at the irradiated fibrotic mediastinum and says, absolutely not, I'm not operating on that, doesn't that inherently default the decision back to us?
It feels like it should.
Doesn't no surgery basically force our hand to do radiation?
No. And that is a massive clinical trap. This is actually board trap number 3.
Okay, unpack that for me.
Assuming that a lack of easy alternatives equals a mandate to irradiate is incredibly dangerous.
But if we don't do radiation, aren't we just abandoning them?
You are never abandoning a patient by protecting them from a fatal complication.
That's a good point.
The comparison of modalities has to be grounded in reality. The alternatives to radiation might include thermal ablation, like, microwave or cryoablation. It might include endobronchial interventions, stenting, or systemic therapy. But crucially, the alternative might just be observation or supportive care.
So doing nothing might be the actual best medical choice.
Exactly. A technically feasible re-irradiation plan might offer only a 20% chance of durable control, but carry a 30% chance of causing a fatal airway fistula.
Oh, wow.
Yeah, so in that scenario, doing nothing locally isn't abandonment. It's superior medical management. No surgery does not mean, therefore, radiation.
That's a hard pill to swallow, but it totally makes sense. Which brings us to step 4. Is the risk knowable?
Right.
When we say knowable, we don't mean perfectly precise, right?
No, absolute certainty in re-irradiation is a myth.
So what does knowable actually mean?
It means that the prior course can be reconstructed with enough fidelity that you can confidently identify the organs that are going to limit your dose.
Okay.
It means you can defend the anatomical registration you're using, and you can mathematically test whether your new plan remains safe, even if your alignment is off by, a few millimeters.
So what if you can't do that? What if a critical structure, like the spinal cord, might have already received 50 gray, but the old records are so degraded you just can't prove it either way?
Then your inability to estimate the risk is itself a recommendation-changing finding.
That completely shifts the paradigm. We always think our job is to figure out how to treat.
Right.
But sometimes the highest level of expertise is concluding that the risk just cannot be bounded well enough to justify the treatment.
Which leads directly to step 5.
Mm-hmm.
Is the expected benefit proportionate to that risk?
Right. The ultimate balancing act.
Like we said, technical feasibility is not clinical justification.
Yeah.
You could use VMAT to paint a beautifully conformal dose around a recurrence.
It looks great on the screen.
Yeah, but if that recurrence is sitting on the exact same patch of esophageal wall that was ulcerated 3 years ago, the technical beauty of the plan is irrelevant. The biology will fail.
So what does the evidence actually tell us about that risk-benefit ratio? Because when we look at the literature on thoracic reirradiation, it's kind of a mess.
It is a total mess.
I mean, it's retrospective series, different fractionations, varying intervals. How do we even make sense of it?
The literature is incredibly heterogeneous, but there are 2 broad signals that emerge loud and clear.
Okay, what are they?
Signal 1. Meaningful, durable local control can be achieved in carefully selected patients.
That's the good news.
And signal 2 is the bad news.
Mm-hmm.
Severe, irreversible, and fatal toxicities have occurred, particularly when retreating central anatomy, where the cumulative exposure to critical structures is high.
For example, there's a lot of enthusiasm right now for repeat stereotactic treatments like SBRT for a new peripheral nodule after prior SBRT.
Yeah, and for small peripheral recurrences that are just surrounded by healthy lung, repeat SBRT has actually shown very promising control rates.
And the literature describes some risk reduction strategies for this, right?
It does. Things like using more fractions like 5 to 8, instead of 3 treating on non-consecutive days to allow for sublethal damage repair, and aggressively managing motion.
But you cannot extrapolate the safety of a peripheral lung nodule to our case anchor who has a central recurrence.
No, absolutely not. Central and ultracentral retreatments are a totally different biological game.
Right, because we are talking about the proximal airway, the esophagus, the major vessels.
Injuries here aren't just a cough or some mild fibrosis. We're talking about fistulas where the airway literally melts into the esophagus or massive hemorrhage.
So the relevant question isn't just, is the tumor in the central zone?
Right. The question is, which specific histological structure is touched, invaded, compressed, or encased by the high-dose region?
Even the prospective phase 2 data we have on thoracic reirradiation, which did show that high-dose retreatment is feasible, that requires careful interpretation. Right.
Very careful. Because in those trials, the first and second courses, the intervals, and the techniques were all highly mixed.
So we can't just generalize it.
No. The correct takeaway from prospective data is not that central reirradiation is broadly safe. The lesson is that intense technical discipline and extremely careful patient selection can pry open a small therapeutic window.
But the margins of that window are razor thin.
Extremely thin.
So let's look at how we actually pry that window open safely. This brings us to reconstructing the first course.
Right.
In our case, Anchor, the patient wants treatment, but we only have a one-page summary that says definitive radiation.
That dreaded one-pager.
I think the best way to conceptualize what we have to do next is with an analogy.
Oh, I love a good analogy.
Reconstructing an old radiation plan is exactly like an archaeological dig. You cannot guess the layout of a buried foundation just by looking at the topsoil and a one-page treatment summary. That's just the topsoil.
That analogy is absolutely spot on. And the most fundamental rule of this archaeological dig is this. The prior prescription is not the prior plan.
Break that down for me. Why isn't knowing the prescription enough? I mean, if the summary says 60 gray and 30 fractions to the right lung, shouldn't I know exactly what to do?
No, because a prescription just tells you what the physician wanted to happen to the tumor.
Okay.
It tells you absolutely nothing about what actually happened to the normal tissues.
Give me an example.
Let's say that 60 gray was delivered using an old 3D conformal technique with anterior-posterior beams.
Standard old school APPA.
Exactly. The spinal cord might have gotten 45 gray, but the esophagus might have gotten 62 gray in the hot spot.
Oh, wow. Okay.
But if it was delivered with VMAT, volumetric modulated arc therapy, the esophagus might have only gotten 30 gray, but a massive volume of normal lung received a low-dose bath.
So a prescription number just completely hides the physical reality of the dose gradients.
Exactly.
So what is the retrieval hierarchy? What specific tools do we need to, dig down to the foundation?
You need the raw data. At an absolute minimum, you must request the prior planning computed tomography data set, the actual CT images.
Right.
You need the structure set, which contains the contours of all the organs.
Yeah.
You need the treatment plan, the 3D dose grid, the plan report, and the actual treatment delivery record.
And what are we looking for in that delivery record?
You have to ask the previous facility, were there sequential boosts? Was the plan adapted halfway through because the tumor shrank?
Mm-hmm.
Were there major machine interruptions? Did the patient actually finish all 30 fractions?
Because if they only finish 20, that completely changes the math.
Exactly.
And beyond the physics, we need the clinical history. We need to know what the dose actually did to the patient.
Right. The physics tells you where the dose went. The clinical history tells you how the tissue responded.
Let's look at the biology. Did they have concurrent chemotherapy?
Which is huge because chemo acts as a radiosensitizer. That means the normal tissues sustain way more double-strand DNA breaks than the physical radiation dose alone would suggest.
Wow. And what if they developed severe pneumonitis?
If they did, their lung tissue has already demonstrated a hyperinflammatory response, and the reserve pool of healthy pneumocytes is depleted.
So they are primed for another injury.
Yes. Or did they have an esophageal stricture? If so, the muscle layer of the esophagus has already been replaced by fibrotic scar tissue.
So you have to reconstruct the tissue's memory, not just the computer's memory.
That is a perfect way to put it.
But what if the digital records are just gone? I mean, it was 10 years ago, the clinic upgraded their servers, and the DICOM files are just lost. What's the rule then?
The rule is, do not fabricate precision.
Okay.
Every step down the retrieval hierarchy adds exponential uncertainty. If you can't get the digital plan, you ask for archived image and dose exports, like PDFs of the dose volume histograms.
And if those are gone?
You look for hard-copied printouts of the isodose lines.
But if you're forced to use those hard copy printouts, you're basically looking at a 2D representation of a 3D problem.
Exactly. You might see a line that says 50 gray, but you don't know if that 50 gray extends 1 millimeter into the esophagus or 2 centimeters.
Right. You're just guessing based on a piece of paper.
And if you are forced to mathematically reconstruct the old plan, where you literally draw the old beams on the new scan and try to guess what they did, you must explicitly state the uncertainty range.
So you don't say the cord got 42 gray.
No, you say, based on a best guess reconstruction, the cord likely received between 35 and 50 gray.
And crucially, the further down that hierarchy you go, the more your final recommendation should pivot away from aggressive retreatment and toward lower risk alternatives.
Absolutely.
So back to our case anchor. Our patient is sitting in the exam room. We know they want treatment. The digital plan hasn't arrived yet. Do we go ahead and pick a prescription?
No.
Do we say, okay, we'll tentatively plan for 50 gray and 5 fractions, and we'll adjust it when the records come in?
Absolutely not. Selecting a prescription at this stage is clinical malpractice.
Wow.
You cannot choose a dose when you are blind to the past.
So what should we be doing while we wait?
What you should be doing while waiting for those records is completing the multidisciplinary review.
Like getting pulmonary function tests.
Yes, you send them to pulmonology for formal PFTs to see what their baseline reserve actually is. You have speech-language pathology evaluate their swallowing. You consult with thoracic surgery and interventional pulmonology. You build the clinical context so that when the old plan finally arrives, you know exactly what biological vessel you are pouring that new dose into.
Okay, let's fast forward. The digital plan finally arrives. We have the old CT, the old dose, and we have our new simulation CT.
Right.
Now we have to map the old dose onto the new anatomy. And this is where we have to talk about registration and the illusion of perfect summation.
Yes. Before you even open the registration software, you must look at the native plans.
I really want to emphasize this because it is so incredibly easy to skip.
It is.
You know, you pull both data sets into the system, you hit sum, and you just look at the composite dose. Why is that so dangerous?
Because a mathematically summed composite dose volume histogram can easily obscure physical reality.
Ow.
You have to review the first course dose on the first course anatomy. Then you review your proposed second course dose on the current anatomy. You're looking specifically to identify where each plan places its physical hotspot.
Give me a scenario where just looking at the sum fails.
Let's say you just look at the summed composite DVH for the airway and says the maximum dose is below your threshold. It looks totally fine.
Okay.
But if you looked at the native plans, you might have seen that the old plan placed a 60 gray hotspot on the anterior wall of the right mainstem bronchus. And your new plan places a 50 gray hotspot on the exact same square centimeter of the anterior wall.
Oh, wow. So you're double dosing the exact same spot.
Exactly. The composite spreadsheet might just average things out and look acceptable, but the physical reality is that you are hammering the exact same microscopic patch of cartilage twice.
And cartilage doesn't heal well.
No. It has a terrible blood supply. You'll necrose. You only catch that by looking at the native plans first.
Okay, so you've reviewed the native plans. Now you have to align them. Registration.
Right.
If I'm a resident at the console, I might think, I'll just use a rigid registration. Line up the spine, lock it in, and we're good. What is the flaw in that logic?
This is board pearl number 3. Registration is a model, not a fact.
Okay.
A rigid, bony alignment might look absolutely perfect for the spinal canal. I mean, the T4 vertebra matches the T4 vertebra.
Sure.
But that exact same rigid registration can completely misrepresent soft tissues.
Because the patient's internal geometry has completely changed?
Exactly. 2 years ago, the patient had a large tumor. Now they don't. They might have lost 30 pounds. So the distance between their chest wall and their mediastinum is completely different.
Yeah, or they might have atelectasis, right?
Exactly. A collapsed lobe, which pulls the heart and the esophagus 2 centimeters to the left.
Oh, I see.
So if you rely on a rigid spine registration, the computer will map the old dose to where the esophagus used to be, not where it is today.
You might think you're avoiding the esophagus, but in reality, you're hitting it directly.
Exactly.
So you have to inspect the registration organ by organ, the vertebral bodies, the spinal canal, the proximal airway, the esophagus, the heart.
You have to ask, what changed? Did the diaphragm shift because they're breathing differently?
The software will always give you a mathematically perfect fusion.
It will, but you have to ask if the mapped dose is anatomically credible.
And that brings us to the siren song of modern planning software, deformable registration.
Ah, yes.
Let's talk about the physics of deformable registration, because people treat it like magic.
They really do.
They think the computer perfectly tracks every single cell from 2023 and maps it to 2026. How does it actually work, and why does it fail?
Deformable registration uses algorithms like B-splines or Demons algorithms to track voxels, which are basically 3D pixels based on tissue density, or Hounsfield units. It tries to stretch and warp the old CT to match the visual shape of the new CT. But the algorithm doesn't understand biology. It just understands grayscale pixels.
I like to think of it like stretching a rubber band with a map drawn on it over a lumpy rock.
That's a great visual.
You know, you can pull the rubber band so the borders match, but the cities drawn on the rubber band are now in completely the wrong physical locations.
That's exactly what happens. In the thorax, you have extreme contrast between air, which is black on CT, and soft tissue, which is gray.
Right.
If a tumor used to be invading the airway, but now it's gone, the deformable algorithm gets completely confused.
What does it do?
It might take a high-dose voxel that was originally inside the tumor mass, and to make the images match, it violently warps that voxel into the wall of the airway, or across a vessel, or into the spinal cord.
It creates a physical impossibility.
Exactly. Deformation is a mathematical model that you must brutally interrogate. It is never permission to stop looking at the original images.
So what is the actual workflow? If one registration isn't enough, what do we do?
The most useful review almost always involves looking at more than one plausible registration.
So multiple fusions.
Yes, you do a global thoracic alignment. Then you do a local organ-focused alignment, say, just focusing on matching the esophagus perfectly.
And then what?
And you ask yourself, does my clinical recommendation change depending on which registration I look at?
Let's apply that to our case. Our global registration and our local mediastinal registration agree perfectly on the spinal cord.
Okay, so the cord is safe.
But they place the esophagus in two different positions relative to the old high-dose region. Under registration A, the esophagus is fine. Under registration B, it gets blasted. What is the trap here?
The trap is twofold. First, the instinct is to average the registrations. Do not do that.
Why not?
Because averaging two different anatomical positions creates a ghost anatomy that simply does not exist in the patient's body.
Oh, wow. Okay, and the second trap?
Second, do not just pick the most favorable registration A just because it makes your plan pass.
Yeah.
That is converting uncertainty into bias.
So what is the solution? What do you actually write in your note?
You state the uncertainty directly. You write, the cumulative spinal cord estimate is robust across all registrations. However, the cumulative esophageal estimate is highly registration sensitive.
And then?
And then you mathematically test whether a clinically meaningful plan survives both plausible alignments.
If your plan is only safe under one specific software model.
It is a dangerous plan. You have to design a plan that is safe regardless of whether registration A or registration B is closer to reality.
To help everyone remember this critical sequence, there is a short mnemonic for cumulative dose assessment, FSMU.
Let's hear it.
F stands for first course native plan review. Look at the old hotspot.
Right.
S stands for second course native plan review. Look at the new hotspot. M stands for mapped composite, where you explicitly state your registration and biological assumptions.
Yeah.
And U stands for uncertainty analysis, where you test alternative alignments. FSMU, first, second, mapped uncertainty. Your final decision has to survive all four of those views.
I love that. That workflow bridges us perfectly into the biological reality of reirradiation.
Because we've mapped the physical dose, but physical dose doesn't translate perfectly to biological damage.
Not at all. And this is where we hit oral board trap number 2, the recovery trap.
Let me play the eager resident again.
Go for it.
It's been 5 years since this patient's first treatment. 5 years? Tissues heal. I'm just going to apply a standard 50% recovery discount to the normal tissues. I'll take the old dose, cut it in half, and use that as my baseline. We can do that, right?
No, you absolutely cannot.
Why not?
Physical dose from courses using different fraction sizes cannot be interpreted as though every gray has the exact same biological effect.
So we have to convert it.
Yes, we use biological equivalence conversions, like the linear quadratic model, to place doses into a common framework. We convert everything to EQD2, the equivalent dose in 2 gray fractions.
But even that conversion is just a mathematical estimate based on generalized cell survival curves.
Exactly. It doesn't solve the problem of spatial uncertainty, and it certainly doesn't tell us how much repair actually happened.
But doesn't the interval matter? If it's been 5 years, hasn't the spinal cord healed at least a little bit?
The time interval clinically matters, absolutely. A longer interval might support selecting a patient for retreatment over someone who was treated 6 months ago.
Okay, so there is some benefit to time.
Yes, but there is no universally validated thoracic recovery function that allows us to erase a fixed percentage of the first course.
Because the cellular biology is complex.
Exactly. Early responding tissues, like the mucosal lining, might repopulate, but late responding tissues like the spinal cord white matter or the vascular endothelium, they do not fully repair.
They just lose their reserve.
Yes, they experience stem cell depletion. The microvasculature suffers chronic progressive obliteration. The tissue might look normal on a scan, but its reserve capacity is just gone.
So if you apply a fixed 50% discount, you are creating false certainty.
Exactly. It's incredibly dangerous if your plan only becomes acceptable after you apply a large, unsupported amount of dose forgiveness.
So how should we document this?
The safe, defensible language to use is, I considered the interval as one factor in my clinical risk assessment. You do not say, I assume this organ has recovered by 50%.
Let's do a deep dive into the specific serial organs that dominate these thoracic reirradiation plans. We have to focus on small volume hotspots, not whole organ averages.
Right.
Let's start with the proximal airway, the trachea, and the mainstem bronchi. What is the actual biology of an airway injury?
Well, the proximal airway is supported by cartilage rings, and cartilage has a notoriously poor blood supply.
Right.
When you irradiate it, you damage the endothelial cells of the tiny vessels feeding it. Over time, those vessels fibrose and narrow.
And if you re-irradiate that same segment,
You cause acute ischemia. The tissue literally starves of oxygen and dies. That is necrosis.
and if it necroses, you get a fistula, a hole between the airway and whatever is next to it, usually the esophagus or a blood vessel.
Right. So when evaluating the airway, you have to look at the anatomy directly. Does the recurrent tumor abut, compress, or invade the airway?
Is there endobronchial disease inside the lumen?
Exactly. Did this specific segment already receive a high dose? Is there cavitation, infection, or a stent?
Because if the new high-dose region overlaps that exact same wall segment, a treatment that looks technical perfect on a DVH might still be profoundly unsafe.
Completely unsafe.
Next is the esophagus. The esophagus is a muscular tube. What are we looking for there?
You need to inspect the length and the circumference of the dose overlap. If you treat the entire circumference of the esophagus to a high dose, you destroy the mucosal stem cells, and you cause severe fibrosis in the muscularis layer.
And that leads to a stricture.
Yes, a permanent narrowing. You must ask the patient about any prior severe esophagitis, ulceration, or stricture and assess their current swallowing function.
And here is the cardinal rule for the esophagus. If the organ has already declared a clinically important injury from the first course, like if they had a stricture that required a dilation, you cannot look at a favorable composite DVH number and pretend the esophagus is fine.
Absolutely not. The biological tissue has already declared that its reserve is gone.
What about the spinal cord?
The spinal cord is the classic serial organ. If you sever one link in the chain, the whole chain fails.
And the biology of radiation myelopathy involves demyelination and vascular necrosis in the white matter, right?
Yes. It is delayed, usually happening months or years later, and it is irreversible. Paraplegia.
Because the consequences are so severe, the spinal cord demands its own separate reconstruction and its own planning risk volume, or PRV workflow.
You never just guess the cord dose from the prior prescription. You have to confirm the actual maximum point dose, review the old cord contour, and determine if your current field overlaps the exact same vertebral level.
And if your cord estimate changes materially based on reasonable registration choices, you must escalate the review, redesign the plan, or reject the reirradiation entirely.
Totally agree.
Then we have the great vessels, the aorta, the pulmonary artery, the superior vena cava.
Major vascular injury is relatively uncommon, but when it happens, it's a fatal blowout,
Yeah.
a massive hemorrhage.
So what are we looking out for?
You have to inspect the specific vessel segment. Look for tumor invasion or encasement. Look for factors that amplify the bleeding risk, like a cavitating tumor or an active infection right next to the vessel wall.
So the level of uncertainty you might tolerate in the lung is completely unacceptable when the consequence is a fatal bleed.
Exactly.
And finally, the parallel organs, the lungs and the heart.
For the lung, a single cumulative number like a combined V20 is just inadequate.
Why is that?
You have to look at regional function. Which specific lobes were previously irradiated? Are those lobes already completely fibrotic and non-functional?
So if they are, irradiating them again might not cause any new functional deficit.
Exactly, but you have to preserve the remaining functional lung. You have to factor in their baseline pulmonary reserve, oxygen requirements, and any systemic treatments like immunotherapy that can drastically amplify inflammatory pneumonitis.
And what about the heart?
For the heart, beyond just looking at the mean heart dose, you really have to look at spatial exposure.
Like focal hotspots.
Yes. A low whole heart mean dose can easily conceal a massive focal hotspot on the left anterior descending coronary artery. You have to evaluate the specific substructures in the context of the patient's baseline cardiovascular risk.
So synthesizing all of this biology, the planning implication is that serial organ safety dictates absolutely everything.
It really flips standard oncology logic on its head.
Usually we say cover the tumor, spare the normal tissue.
Right, but in thoracic reirradiation, you might have to compromise target coverage to protect a serial organ.
You might have to restrict the target purely to gross disease with zero margins for microscopic spread.
Or you might have to pivot to a lower intensity schedule. Or honestly, you might have to reject radiation entirely.
That reality leads us right into the clinical execution. We know the biological limits. How do we translate this into a safe plan? And how do we communicate the gravity of this to the patient?
First, a new simulation is mandatory. You cannot just use an old scan.
Right. The new sim has to reflect the patient's current anatomy and what they can actually tolerate today.
Safety today comes first. If they were treated with their arms up above their head 5 years ago, but now they have shoulder arthritis and can't hold their arms up, do not force them.
Simulate them with their arms down.
Because if they're in pain, they will move during treatment, and a 1 centimeter movement can push a hot spot directly into the spinal cord.
But you must explicitly document those positional differences before you map the old dose, so the software differences aren't mistaken for biological recovery.
Exactly.
And regarding drawing the target volume, do not enlarge the gross target merely to compensate for your own uncertainty about the registration.
No, don't do that.
If you aren't sure exactly where the old dose was, making your new target bigger just guarantees you will hit more normal tissue.
That is how you consume your therapeutic window completely unnecessarily.
When you hand this to your dosimetrist, you must establish an explicit priority order, right?
Yes. In standard planning, target coverage is priority 1. In thoracic reirradiation, the hierarchy is very different.
Run us through it.
Priority 1, avoid catastrophic serial organ injury airway, esophagus, cord, vessels.
Okay.
Priority 2, preserve enough functioning lung and heart to support life.
Makes sense.
Priority 3 is gross target coverage. And priority 4 is limiting intermediate dose spill. Notice that hitting the tumor is number 3 on the list.
We really have to make that trade-off painfully explicit. Technical feasibility asks, can I physically map out this plan? Clinical justification asks, does this plan offer a meaningful benefit at a risk the patient should reasonably accept?
Exactly. If protecting the airway means the tumor only gets half the dose it needs, well, you don't really have a definitive plan anymore.
And once you actually start treatment, you can't just set it and forget it. You need robust adaptation and strict stop rules.
You must use daily volumetric image guidance, like a cone beam CT, every single day.
And you aren't just looking at the tumor to line it up.
No, you are verifying that the airway, the esophagus, and the chest wall remain in the exact position you planned for.
Because things change during treatment.
The patient might develop atelectasis, a lung collapses, and suddenly the esophagus is cooled directly into the high-dose beam.
So you have to trigger an adaptive review, pause treatment, and replan if the anatomy shifts.
And the stop rules must be absolute.
Give us an example.
If the patient comes in for fraction 10 and reports new, significant coughing up of blood hemoptysis or rapidly progressive trouble swallowing, that means pause and reassess.
It does not mean give them some throat spray and push through.
Absolutely not. It does not mean skip today and try again tomorrow. The biological risk model has fundamentally changed.
So you must stop, review the imaging, involve your multidisciplinary team, and decide if treatment needs modification or if it must stop entirely.
All of this complex physics, biology, and uncertainty requires a highly specific conversation with the patient.
It's not standard consent. It's high-risk consent.
Exactly.
I want you to model this for us. If you are sitting across from our case anchor patient, what exactly do you say?
It has to be explicit and use plain language.
Right.
I would sit down and say, radiation may offer another chance to control the tumor in your chest, but the nearby normal tissues have already received a lifetime dose of radiation. We can estimate the combined exposure by mathematically mapping your old plan onto your new scan, but I want to be very clear. That estimate is not perfect. Your anatomy has changed, and human tissues do not recover in a completely predictable way.
Very.
I'd go on to say, the main risks in your specific case involve your breathing tube and your swallowing tube. Serious injury could include severe narrowing, ulceration, a dangerous connection forming between the structures, or major bleeding. Lung inflammation and heart injury are also possible. Some of these injuries could be irreversible, or they could be fatal.
Wow, okay.
Then I'd say, we're going to compare this radiation plan with other treatments, and with the option of doing no additional local treatment. If we proceed, this plan will undergo a specialized review. During treatment, we may need to reduce the dose, change the schedule, adapt the plan, pause treatment, or stop entirely if your anatomy or symptoms change. I want you to fully understand both the possible benefit and the deep uncertainty before we make a decision.
That is the definition of high-risk consent. It names the purpose, it names the uncertainty, it identifies the specific structures using terms like breathing tube and swallowing tube. It doesn't shy away from the word fatal, it lists the alternatives, and it reinforces the very real option to walk away.
That leads us perfectly into the final segment. Let's crystallize these complex management decisions into concise, testable clinical vignettes.
Yes, this is the board blitz.
First, a quick recap of the 3 major traps we discussed today.
Trap 1. The illusion of summation. Treating dose summation as a physical measurement rather than a software model. Do not just add the plans and check the constraints. Review the native plans and defend your registration.
Trap 2. The recovery trap. Discounting the first course by a standard percentage. Do not convert elapsed time into a known amount of biological organ recovery.
And trap 3. The mandate to irradiate. Assuming a lack of surgical alternatives equals a mandate to do radiation. A technically feasible retreatment might offer no meaningful benefit but carry catastrophic risk.
Now for the vignettes. Let's test this in reality. I'm going to set up 3 clinical scenarios based on the source material. For those of you at the console, commit to a management decision in your head before we debate it.
Vignette 1. A patient presents with a biopsy-proven isolated central thoracic recurrence. Good functional status, no unresolved prior toxicity. However, the outside record contains only the prior prescription, 60 gray, and a brief 1-page summary.
Okay.
My instinct is, the disease is localized, they are healthy, let's just choose a definitive SBRT schedule and treat them while we wait for the records because we know SBRT is great for isolated disease. Tell me why I'm wrong.
You're wrong because localized disease only makes reirradiation worth evaluating. It does not establish safety.
Right.
The prior prescription of 60 gray alone cannot show you which microscopic segment of the airway or esophagus received the dose. If you choose an ablative SBRT dose now, you might unknowingly double dose the right mainstem bronchus and cause a fatal necrosis.
So what's the right move?
You must delay prescription selection until all original digital planning data, the CT, the structures, the 3D dose grid, is retrieved and processed. Do not rush to SBRT and never add prescriptions blindly.
Vignette 2. The records arrived. The mapped composite dose volume histogram looks totally acceptable. But the esophagus has shifted significantly between the old scan and the new scan. We run 2 different, totally reasonable registrations.
Okay, 2 valid models.
Registration A places the cumulative hotspot on the left wall of the esophagus. Registration B places it on the right wall. My instinct is to just average the 2 registrations to get a middle ground, or just pick the one that gives a lower dose so my plan passes. Why is that the wrong move?
Because averaging 2 different registrations creates an anatomy that doesn't actually exist in the patient's body. And picking the favorable one converts uncertainty into confirmation bias.
Right.
Registration uncertainty is profoundly meaningful for a serial organ like the esophagus. Your response must be to review both native plans, inspect the esophagus along its entire length, and mathematically test the proposed plan under each plausible registration.
And if it fails one?
If your plan is only safe under one specific alignment, you must redesign the plan or change your clinical intent.
Vignette 3. During our chart review, we learned that the patient has persistent, severe swallowing dysfunction. They had grade 3 esophagitis during the first course and required dilations for a stricture.
Not good.
The new recurrent target overlaps that exact same esophageal segment. But I look at the composite DVH, and the numbers are actually really favorable. The math says we are under the limit. My instinct says we have a green light to proceed with aggressive reirradiation because the DVH passes. Why am I stopping?
You are stopping because the biological organ has already declared a clinically important injury in the exact segment you are targeting again.
No, the math doesn't matter here.
No, that is a recommendation-changing clinical finding. A favorable composite number on a spreadsheet does not magically restore the depleted stem cells or fix the fibrotic muscle layer of that esophagus.
A declared biological injury overrides the DVH every time.
Every time. You must step back, involve GI specialists, and strongly reconsider alternative local therapy, lower intensity palliation, or simply no reirradiation.
Let's bring it all home. We need the final oral board quality attending recommendation for our specific case anchor patient, the one with the central recurrence, good performance status, and all records finally retrieved. Give us the clean synthesis.
For our central non-small cell lung cancer recurrence patient, the synthesis sounds like this. This patient has a biopsy-proven isolated thoracic recurrence and a realistic possibility that durable local control could alter their clinical course.
Hmm.
I would recommend a carefully selected, more conventionally fractionated conformal reirradiation approach rather than reflexively choosing an ablative SEB or T schedule, because the recurrence lies centrally near the proximal airway and esophagus.
And for the dose.
I would base the final dose recommendation on a strict review of the native plans, organ-specific registration, cumulative biological comparison using EQD2, and sensitivity testing across all plausible alignments.
What are the priorities?
I would explicitly prioritize the avoidance of catastrophic airway, esophageal, spinal cord, and vascular injury over nominal target coverage. I would proceed only if the plan remains clinically meaningful and biologically acceptable across reasonable uncertainty, and only after pretreatment, peer review, independent physics verification, and high-risk informed consent.
The clarity of that logic is exactly what we are aiming for. It balances the biological reality with the physical uncertainty.
That's the goal.
I want to leave everyone with a final, slightly provocative thought to mull over. Every single retreatment decision you make narrows the patient's future options. But more importantly, the way you archive your plans today, the meticulousness with which you document your positional setups, the clarity of your dose grids that becomes the first course for the next clinician who might see this patient in 3 years.
That is so true.
High-quality digital archiving isn't just administrative paperwork. It is a critical, life-saving clinical intervention that you are performing for the future. Get show notes and complete practice oral boards at radoncsmartlearn.com and subscribe for our next episode. Thanks for tuning in.